Can you restart my timer, please? Thanks. Okay, so first of all, why do we need prediction? Plenty of babies, especially in India, 3.5 million babies. If you average them about 3 or 4 times a day, or 3 or 4 time visits, that's 17 million examinations, and we have less than 200 ROP specialists to do it. So we thought there has to be a way of predicting whether these babies will get the disease, and if it will work best if you can do that during the very first examination. So these are multifactorial. This was something that you've heard of the Winthrop trial, of course, where the weight gain was used as a predictor. We looked at the weight loss. Babies lose weight and then they gain that back again, and the number of days to take to gain back was a modest predictor. But we were looking for non-invasive biomarkers. So this was exciting work we're doing in our lab. First of all, I did not think that preterm babies who are 3 or 4 weeks of age can even produce tears, but clearly whatever that is that we are collecting on the filter paper is being assessed, and that's goes up. And if you can see this video here, you can see it's wet up till the 20 millimeter mark. So that then goes into our lab and it's processed. It's of course deep frozen, and then it goes through a cytometric bead exam assessment, centrifuge, so on and so forth. All of this is done by some of our scientists. And then eventually we were looking at about 80 molecules. We've brought that down to 10 right now, and that's what we recently published. So we all know the enemy is really VEGF and angiogenin, but there are so many other chemokines, cytokines, and adhesion molecules. The important thing is to understand how these are correlated. So these are time-lapse videos to show you that this is a baby who went from immature retina to a mature retina. Okay, that happens most of the time. But what we were able to look at is these biomarkers, how they changed over time. And therefore, studying that would help us assess which of these molecules went up or down when they became mature without disease. Here's the other set. So who had some ROP, what we call type 2 ROP. Type 2 ROP is ROP that needs follow-up but doesn't need treatment. And there's some other factors were playing a role. And the important thing is the ratio of these factors is what we studied. And finally, the guys whom we're really interested in, the babies who require treatment. So these were treatment requiring ROP babies. And again, we were following them serially to look at what molecules go up and down. And these abbreviations are from that table where I showed you those 10 molecules. So this was our first publication where we looked at that. And what's very interesting is that the babies who have the least VEGF and angiogenin at the first screening had the highest chance of having ROP later, which basically means that VEGF is required for vascularization and they didn't have it in adequate amounts in the first screening. And then therefore they predicted better, worse disease. Now this we kind of knew, but what's important here is, can we correlate that with the birth weight and the gestational age, therefore coming up with a formula? So if I give you any baby whose birth weight and gestation age and then you can run some of these formulae, which some of them you assess and some of them are demographic details, then can you come up with a formula to predict these babies? And that comes to our second paper, where we looked at inflammatory markers. Some of them you saw. And what we found is that rantes and interleukin 8. Now, interleukins is a family where some of them are protective for vascular growth and some of them harm vascular growth. So low levels of interleukin 6, higher levels of interleukin 8, for example, correlated with those who are going to develop ROP. Now, the names of these molecules are not important. But what's important here is that we're able to assess that in the very first screening or the subsequent one more screening to be able to predict whether these babies will become worse or become better. And now, if that is a timeline, you should be able to tell the mother when to come back with these babies, because otherwise traditionally you're screening these babies every week or every 2 weeks, maybe without any rhyme or reason. But now here with a score, we are able to predict when or which babies will get the disease and possibly when. And this is our more recent publication where we're looking at vitamin D as a possible therapeutic agent. So if it was low vitamin D in some places and they correlated for higher ROP, can we prevent that by giving vitamin D prophylaxis? So that's really where it is. Now, what we're trying to do is make this into a kit. Right now, all of this is happening in a lab, and that's not really useful for the outreach. But just like a kit that measures the glucose, blood glucose, you take a drop of blood and you put it on a filter paper and you put it into that and it gives you the readout. What we are trying right now is to do the outreach. This is our KidRaw program. We screen in about 144 centers. So what we've divided them now is into zones. and we are able to take this kit that you see here. It's slightly bigger right now. It's being validated in multiple centers, and that's where we are able to see it in real world. Our problem so far has been maintaining the cold chain, because in the rural areas, bringing it to our lab has been a problem. But what if we can assess it then and there itself? So that's how we've divided into zones, and this work will be shortly published. Perhaps another 6 months, we'll finally get our data. So thank you very much.